That very kind introduction. So just my disclaimer to begin with, it's going to be all downhill from here on. So just be prepared. All right. So I probably should start first with the disclaimer, because it seems to be the most frequent question I get asked. No, I did not generate the slides that you're going to see today using ChatGPT. So I just want to make that very clear. All right. So real pleasure to be here talking about AI and precision health. Beautiful building. It's my first time in this really lovely building. So congratulations to all of you for having this. I'm eagerly looking forward to moving into HSRV2. So hopefully that'll happen next month. I guess the more formal disclosure is the fact that some of what I'll talk about today has been licensed to a company, Picture Health, that I am a co-founder and equity holder on. I am on scientific advisory boards for a few different companies, and we have a number of sponsored research partnerships with pharmaceutical companies. I guess my real disclosure is the fact that I do have a social media account, and I am on Twitter. So if any of you find any of what I'm going to present today remotely appealing, please feel free to give me a follow. So I just want to set the stage a little bit for today's talk, and we've heard a lot about AI. And there's been significant progress and advances in the development of AI and machine vision tools from a diagnostic perspective, the ability to look at X-rays, CT scans, MRI scans, and so on to be able to identify the presence or absence of disease. But perhaps just as important, if not more important, is the use of these technologies to look at routinely acquired data to be able to prognosticate outcome, and more critically, to predict therapeutic response, because it's really the development of these technologies from a prognostic and predictive standpoint that will truly help us realize the promise of precision medicine. And something that has happened over, I'd say, the last couple of decades is the fact that we are routinely acquiring a lot of information across multiple different length scales for characterizing a number of different diseases. And I want to start off with an example in the oncology space, and this is specifically in the context of prostate cancer, where there's a region of prostate cancer in the white box. That's the region of adenocarcinoma. You're looking at a T2-weighted MRI scan. And the T2-weighted MRI scan provides morphologic information about the disease. But the thing with multiparametric MRI is the fact that you can actually look at multiple different parameters. You can look at different variables. We have the ability now with the digital side imaging to be able to look at subtle patterns of cellular architecture. We can actually look at greater resolutions, get down to the cellular level and start to look at the shapes and the morphology of individual cells. But what we're also doing on a fairly routine basis is acquiring some kind of omics, typically multi-omics data, be it proteomics, genomics, and more frequently, things like single cell and spatial transcriptomics. And my bigger point here is not the prostate cancer piece, but more the fact that for a number of different disease indications, a lot of this multi-scale, multimodal data is being routinely acquired. And so the opportunity, therefore, is really to leverage the plurality of information that we are routinely acquiring for so many different diseases. And by using machine learning and AI technologies to be able to integrate, coalesce, and combine all of this information so that we can create better predictors for improved disease diagnosis, prognosis, as well as treatment response. Today, when we talk about artificial intelligence and machine learning, inevitably, most of us conflate a particular kind of machine learning with all of AI or all of machine learning. And I'm talking about deep learning, which is a specific kind of machine learning algorithm. And what you're actually seeing here is a particular specific type of deep learning algorithm. This particular one is called the stack sparse autoencoder, an algorithm that we actually developed about 9 years ago, or more specifically applied it to a problem in digital pathology where we were looking at trying to identify individual cancer cells on pathology images. And the big advantage of this particular kind of approach was the fact that by simply providing annotations of the cells of interest to one of these networks, this is a stack sparse autoencoder, like I mentioned, the network was then able to learn representations associated with the individual cells and was then able to identify the precise location of these individual cancer cells on the pathology image. So the power is the fact that even somebody who doesn't really understand pathology can stand up one of these networks simply on the back of annotations of the target of interest. And the network then is able to learn appropriate representations to really distinguish the category of interest from everything else. But the challenge is that these representations often are extremely opaque. It's very unclear as to exactly what the network is learning. And that's why a lot of these algorithms are often labeled mysterious machines or black box approaches. And the main reason being that the representations that are being learned are just not, are very abstract. They're not very interpretable. And so that represents a challenge, particularly when you think about clinical adoption or translation of these algorithms. And I want to give a very specific example of where the lack of interpretability can actually result in what I would call a catastrophic failure. This is an example from our own work about 5 years ago, where we were working with the University of Pennsylvania and trying to develop an algorithm to identify the presence of heart failure on tissue biopsies. So specifically, we were looking at endomyocardial biopsies, and we were trying to see whether an AI algorithm could learn patterns of these biopsy images to identify the presence or absence of heart failure. So we got about 100 images from the University of Pennsylvania. These were all scanned at the University of Pennsylvania. These then came over to our group at Case Western, where we developed an AI algorithm, specifically a convolutional neural network, to be able to identify the presence or absence of heart failure. So we used 100 images, trained our network, and then got another tranche of 100 images from the University of Pennsylvania, and that represented the test set, the independent validation set. And just for laughs and giggles, we actually had two other experts also look at these images and come up with their own independent prediction of the presence or absence of heart failure. And so when we looked at the results on the validation set, the results were spectacular. The machine came in with an area under the curve of 97%, and the two expert pathologists who had looked at these slides had an average area under the curve of about 74%. And so we were ecstatic. We were thrilled. Of course, I reached out to the Case Western Research University's marketing folks, and I said, we got to publicize this. We got a lot of publicity out of the work. You can see G Reports call this out as one of the 5 coolest things on the planet this week. I was at an NIH study section back in 2018, and one of my students wrote to me saying, the press release that the university had put out was trending on Reddit. This was a new social media platform for me. I wasn't really familiar with Reddit, but when he sent me that note, I went on, and the way this social media platform works is the more people commenting on a story, the more the story starts to rise in the rankings. And so, you know, the hook here was, of course, the fact that the machine had beaten the doctor. You can see there were a lot of comments. I sort of managed to briefly break into the top 10. And I went in and looked at some of the comments, and I thought I'd share one in particular, which really caught my attention. All right, so that was all fun and games. But the fact is that soon after the story came out, a couple of months later, actually, we got another tranche of about 70 images from the University of Pennsylvania, and we ran the same set, this new set of 70 images through the same network that we developed. And what we found this time was that the performance had gone from that dizzying height of 97% down to 75%. And that was very unexpected. And it was very unexpected for a few different reasons, because we hadn't changed the lab or the site that we were working with. The scanner that was used for digitizing the slides had not changed. And so it was very surprising why this network that had been trained on images on slides from a patient demographic and patient population that was relatively unchanged, from the same lab where the slides had been prepared, from the same scanner that had been used to digitize the first set of slides, why the performance would dramatically drop from 97 down to 75%. And of course, I wasn't smart enough to figure this out. Thankfully, that's why you have graduate students. And graduate students were able, my 2 graduate students at the time, were able to go in and figure out what had happened. And what had happened was that in between the first tranche of images and second tranche of images, a remote software upgrade had been applied to the slide scanner, which had very subtly changed the distributions of the slide appearance. And this very subtle perturbation in the appearance of the slide images had not really had an impact on the human readers, but had very subtly impacted the performance of the network. And that was the reason why the network performance had so dramatically dropped. And this is a point that's getting a lot of attention. This is just one article. There have been a series of articles that have talked about this issue of the black box nature of these AI algorithms. Here's another great example that I like to use. This is from Sameer Singh at University of California, Irvine, where he and his student developed an AI algorithm to distinguish huskies from wolves. And they reported a 99% accuracy in distinguishing huskies from wolves based on images that they pulled from the internet. Now, Sameer, who's clearly way smarter than I am, because when he saw those performance results, instead of running to his marketing and communications office and putting out a press release, he said, no, this seems really fishy. This seems too good to be true, because from a human standpoint, this is a very difficult problem to crack. These animals are very, very similar to each other. So something else is going on. And what they were able to discover was the fact that the AI algorithm was actually picking up not features of the face of the animal, but the fact that huskies inevitably were on a white background, right? There was snow in the background, right? Huskies typically tend to be in colder climes, and that's what the network was picking up. And that's a very important message, because if you don't understand what the network is picking up, if you don't understand these representations, then how do you actually start to trust these algorithms, and how do you use these algorithms, particularly for high stakes decisions? Cynthia Rudin at Duke University has written extremely eloquently on this topic, that particularly for high stakes decisions, for problems like one encounters in medicine, using the black box and trying to use the black box is really potentially opens you up for catastrophic failures. In fact, she did not mince words, and said that one really needs to think about designing models that are inherently interpretable. And so that really gets to the crux of my talk today. I want to talk about three different aspects as we talk about artificial intelligence. One, the topic of interpretability, the concept of a black box versus a more intentionally interpretable approach. The issue of reproducibility, from the experience that we had with the heart failure example that I mentioned. One of the things that we've really started to think about very deeply is the reproducibility of these algorithms. Do these algorithms work from one side to another? It becomes really important to stress test and bench test these algorithms across a plurality of sites. And then the third topic, which is equity. Do these algorithms truly work across a diversity of populations? And are we ensuring that these algorithms are being trained in a way that they do work on not just a particular population, but across multiple different populations? So what I'd like to do over the rest of 30 minutes is really just talk about these three attributes of these three aspects and pepper it with a few different examples across cardiovascular disease, kidney disease, as well as ophthalmology. So first, I want to talk about this concept of sort of deep phenotyping. I do apologize that this very irritating taskbar uses to go away at all. But I want to talk about the ability to converge both the power of deep learning as well as intentional features. This is an example from a radiographic use case or radiographic exemplar that we've been working on. We've been doing a lot of work with chest CT scans, specifically looking at lung cancer. And deep learning, in spite of its failings, has the utility that it is very powerful, and without a great deal of supervision can be used to essentially identify targets of interest very well. In other words, you can use this to deeply phenotype an image or segment an image. So in this case, we have actually used deep learning to go in and identify the nodule of interest or the lesion of interest, identify the perilesional area, use it to identify the vascular network or the vascular the vascular network associated with the tumor. And having done that, having used the deep learning approaches to phenotype the lesion and its surrounding habitat, then one can go in and start to derive intentionally interpretable features that reflect the heterogeneity of the lesion and the surrounding habitat. Look at the twistedness and the tortuosity of the tumor-associated vasculature, look at the shape of the lesion, and basically convert this image into a series of quantitative interpretable image biomarkers. And one can do that
both with radiology, but one can do that with pathology. So going back to that example that I showed you with the endomyocardial biopsies, instead of using a black box approach to make directly make predictions on a slide level, one can actually use the power of deep learning to first go in, segment out the individual targets of interest. You can identify the individual cancer cells, immune cells, identify the different tissue compartments. So identify the stromal compartment, the epithelial compartment, and then start to look at spatial statistics that capture the architecture and the spatial arrangement of the different cell types by also invoking the geography, in other words, where the cell is physically located within the tissue slides. Again, using the power of deep learning to do the segmentation and the partitioning of the slides, but then invoking a series of interpretable image features from those slide images. And while I won't actually talk about most of these examples, I just want to throw this out here just to give sort of a quick snapshot of the opportunities. This is actually work from our group over the last 5 years, where we've taken these deep phenotyping approaches, combining the power of deep learning with interpretable features, and really applied it across a plurality of different indications. There are multiple different cancer types in the left, multiple different combination types that we've looked at to be able to predict therapeutic response. And what we've shown is that by looking at pathology images, by looking at radiographic images, and by invoking these interpretable, handcrafted feature, engineered features, we're able to look at the ability to predict therapeutic response and therapeutic benefit across multiple different combinations. So with that, I want to sort of give some specific examples, and I'm going to try to steer clear of oncology and focus instead in the context of, like I said, cardiovascular, kidney, as well as ophthalmology examples. And this is some work that we've been doing with Laura Barassoni at Duke University, where we've been interested in looking at kidney biopsies, and specifically in the non-cancerous space. One of the areas that we've been very interested in is diabetic nephropathy and related glomerular diseases, where we've been using the power of deep learning, like I said, to first deeply phenotype these images. This is from work that we published a couple of years ago, where Yijiang Chen, a grad student in my group, showed that these networks could be used to identify individual structures of interest on kidney biopsies. In other words, we could identify the individual glomeruli, identify glomerular tufts, capillaries, and all of this with a very, very high fidelity, with a very, very high accuracy. This is an example in the context of proximal and distal tubules, where the network could be used to go in and identify individual structures and individual primitives. And you can see here that, again, leveraging the power of deep learning allows us to come up with very accurate segmentations of the target of interest, of the structure of interest. And you can see some quantitative results there at the bottom of the slide. These are interstitial capillaries and peritubular capillaries that we are able to identify also on these tissue slide images. But like I said, the real opportunity is that using deep learning to segment and phenotype these different targets of interest, but then to look at intentionally interpretable features from the get-go. And in this paper that's just been accepted in Kidney 360, Yijiang again showed that looking at very simple features relating to the shape and the size of peritubular capillaries on kidney biopsies, that we were actually able to predict outcomes, specifically 40% eGFR decline or kidney failure in patients with glomerular diseases like diabetic nephropathy, based on a very simple set of features. But the key here was, again, leveraging the power of deep learning to go in and segment and phenotype these kidney biopsies very intensely. But having done that, to then be able to invoke more interpretable features that relate to just the shape and the dimensions of these peritubular capillaries. And what we showed was that in patients who did have a kidney failure versus those who did not, there were significant differences in the appearance of these peritubular capillaries. In fact, in patients with kidney failure, the peritubular capillaries tend to be more crushed in appearance, and in patients who do not have kidney failure, the converse was true. So that's just one example where you can use the power of deep learning, but then employ more interpretable features to be able to make machine-based predictions of outcome. I want to go back to that. We went back to the same problem and said, well, could we look at an alternative set of features that could potentially predict cardiac rejection from these endomyocardial biopsies. And in work that we published a couple of years ago in the European Heart Journal, with the same collaborators at the University of Pennsylvania, we were actually able to show, firstly, on a much larger cohort, almost 2,300 biopsies from five different sites, that looking at the immune architecture from these whole slide images, so not looking at a black box representation, but specifically looking at the immune architecture, specifically looking at the interplay between myocytes and lymphocytes on these endomyocardial biopsies, that we were now able to predict cardiac rejection in these patients with an AUC of 98%. But what we did ensure in this paper that the number of images was significantly larger, in fact, a log order larger than what we previously reported 3 years ago, and actually had data from multiple different sites. In this particular case, we had 5 or 6 different sites. The good news was that the AUC was consistent. We actually reported that the area under the curve was consistent across different sites. And again, the point here is the fact that we were looking at intentionally interpretable features as opposed to a more abstract representation from a deep learning network. Right. So just a few more examples. Sorry, this keeps coming. Keeps coming back. Okay. This is some more recent work from our group. Kai Yuan, who's a postdoc in our group, has been looking at biomarkers of stromal architecture in cardiac allograft remodeling processes. He's found that looking at collagen architecture, so collagen, of course, is a protein, and using machine learning, we've been able to segment it out on routine H&E images. And what Kai showed in the paper that's currently under review is the fact that collagen architecture is differently expressed in patients with differential clinical trajectory. So in patients who tend to have worse outcome or are at risk for MACE events downstream, tend to have a very different inflammatory reaction or specifically collagen architecture compared to patients who have a better prognosis. So what we were able to do in this particular work was to first use deep learning to segment out the collagen architecture and actually use mathematical entropy-related features that captured the disorder with the collagen architecture and found that the arrangement and the architecture of the collagen was significantly different between patients who had differential prognosis. Right. So with that, I want to switch over to radiographic or radiologic images, and I want to give an example of some of the work we've been doing in the context of brain imaging. Is there a way that some of the lights could be dimmed there? Great, thank you. Thanks. So this is a significant problem in brain tumors is that patients with brain tumors typically will get chemoradiation. And after they get chemoradiation, they come back for a follow-up MRI scan. On that follow-up MRI scan, very often something will show up. And the question now is, what is showing up? Is this an example of the treatment effect, that is radiation necrosis, which is a benign condition? Or is this a recurrence of the tumor? And very often neuro-oncologists and neuroradiologists have a hard time being able to tell from an MRI scan alone whether what they're seeing is a benign condition or is it a recurrence of the malignancy. So in our group, we started to look at these MRI scans and came up with an interpretable approach or interpretable feature to be able to try to capture the differences in the morphologic appearance of the MRI scan, but to do it at a pixel by pixel level. Specifically, what we were able to do was at a pixel level, identify the dominant edge or dominant gradient. Now, this was done after the images had been acquired. So we had the scans, we identified the dominant edge on a pixel by pixel basis, and then use the concept of entropy from high school physics to be able to capture the relative order or disorder with respect to these orientations. It turns out that you could convert these MRI scans into color maps like the ones that you see here, which reflect the entropy content in these images. What you're seeing here with the deep reds are areas where there's significantly high entropy, and that in turn reflects the fact that significant morphologic heterogeneity. You can see on the left panel, there's a lot more entropy, therefore a lot more heterogeneity compared to the right panel. So no surprise that the left panel actually corresponds to recurrent tumor and the right panel corresponds to radiation necrosis. And so even though these were really difficult to tell visually apart on the MRI scans, use of these interpretable features and converting it into the maps that you see here allowed for a more visual, qualitative, but also quantitative distinction between these two very similar appearing presentations. We've taken this approach and applied it to different problems in the cardiovascular space. It's work that's almost 10 years old now, work done by Tao Wan, who was a postdoc in the group. And Tao was able to show that looking at variations in these entropy features, in these textural patterns, and doing it not just at a static time point, but really looking at changes in the textural or the entropy values over the different phases of the MRI scan allowed us to distinguish different types of atherosclerotic plaque. Specifically in the preclinical model, this is in a rabbit model, we were able to distinguish vulnerable from stable atherosclerotic plaque. Just as a disclaimer, I should mention this technology ultimately got licensed to a company called Elucid Bioimaging, and in 2019, this work this technology received 510(k) approval. So this is actually now in the clinic, and I just found out that it's actually being used here in Emory Radiology. But this idea of entropy is really powerful. So Deshna, was sitting at the back of the room there, has been with us for a few years, and she's been exploring the use of these entropy features in the context of different eye diseases. This is some work where she's been looking at OCT scans and found there are significant differences in the appearance of OCT scans in terms of these entropy features. Again, reflecting a diversity in the underlying morphologic appearance in macular edema and other retinal vascular diseases. Specifically, what she showed in this work was that differences in the morphologic heterogeneity was associated with treatment response, specifically an anti-VEGF drug called aflibercept. And so we were able to predict in advance of treatment as to which of these patients were going to respond to aflibercept, this anti-VEGF drug, versus patients who were not going to respond. A few more examples. This is work that Suresh has been doing along with our collaborators at the Cleveland Clinic in the context of neovascular AMD. Again, these features from OCT scans, the entropy features from OCT scans were associated with anti-VEGF response, this time in the context, like I said, with neovascular AMD. Another example here in the context of atrial fibrillation, this is work we've been doing with the Cleveland Clinic, where we've been trying to look at CT scans of patients who've undergone ablation for atrial fibrillation to be able to predict the risk of recurrence. So one of the challenges is in patients who have AFib is that you get treated with a process that's called cardiac ablation, but there's a high likelihood that some of these patients will have a recurrence of AFib. And one of the questions that we were trying to ask in this project that's ongoing with the Cleveland Clinic is which patients are likely to have recurrence of AFib and which patients are not. And are there particular features on the chest CT scans that could potentially identify which of these patients are predisposed to AFib recurrence versus not? This is work that was done by Thomas Adefasu, who was a postdoc in the group about 5 years ago. And we took a slightly different approach. We took what is called an atlas-based approach to try to understand from a population-based perspective, could we start to learn whether there were particular areas of the heart that were predisposed to a recurrence of AFib? So what we did in this particular case was to create a cohort of patients that had a recurrence of AFib post-ablation, but at the same time also had a cohort of CT scans corresponding to patients who did not have a recurrence of AFib post-ablation. Thomas was able to create what are called atlases, a canonical representation of the heart from multiple different chest CT scans, and he created an atlas for patients who did have recurrence, patients who did not have recurrence, then was able to overlay and superimpose and actually create a difference atlas between the two populations. So patients who did and did not have a recurrence of AFib. And what we were able to find was that there were particular areas that lit up on this difference atlas, suggesting differential morphology between patients who did and did not have a recurrence of AFib. Specifically, what we were able to find in this work is that the left atrial appendage, left atrium, and the pulmonary veins all seem to be implicated in the likelihood of recurrence. In other words, those seem to be the areas that were predisposed to a recurrence of AFib. After Thomas left the lab, we had Marjan, another postdoc in the group, who then took this work further. And she was able to develop, using both the entropy features, but also fractal-based approaches, which were able to capture subtle changes in the shape of these different structures in the heart, and showed that by a combination of the entropy texture features as well as shape-related features, we could start to appreciate subtle differences between the left atrium, the left atrial appendage, as well as the pulmonary veins between patients who did and did not have recurrence post-ablation. And just going to sort of, in the interest of time, sort of study the math here, you can appreciate that this is the heart, the pulmonary veins, and she was able to identify subtle differences in the shape of the pulmonary veins, both the primary and the secondary branches, between patients who did and did not have recurrence post-ablation. The concept of shape is a very powerful one, and it's one that keeps coming up in other indications as well. Again, back to Sudeshna's work, where Sudeshna has used a fractal-based approach to quantify differences in the shape of the sub-RPE compartments on OCT scans, specifically looking at patients who have progressive disease versus non-progressive disease in the context of geographic atrophy. She was able to show that if you look at these compartments and quantify the shape of the compartments, there were significant differences between the progressives and non-progressives. Progressives tended to have a much more undulating, irregular kind of shape or differentiation between the compartments compared to the non-progressives that had a much smoother shape. And that was reflected in these fractal-based features. And you can see just this very simple feature alone showed very clear separation between the progressives and non-progressives for dry AMD. Just another example, back to AFib. This is work, again, being driven by Kai Yuan as well as Sarah Mohammadi, who's also a postdoc in the group. And they've been looking at tissue specimens corresponding to the left atrial appendage. So working with the Cleveland Clinic, we've been able to look at surgically excised tissue specimens corresponding to the left atrial appendage. And again, looking at collagen architecture, showing significant differences in the morphology between patients who do have AFib versus patients who do not. But even beyond that, we've actually been able to show that the collagen architecture features are significantly different between different types of AFib. So if you looked at paroxysmal versus persistent AFib, two different types of atrial fibrillation, there were significant differences in the morphologic appearance of this collagen architecture. And so this was very, very insightful. I want to switch over in the last few minutes to some of the other works ongoing in the group in the context of cardiovascular disease. This is work being led by Gaurav Modanwal, who's also in the back here. And Gaurav published a paper very recently that I think was shared with the group, where he showed that using machine learning, again, using the power of machine learning, we could do a deep phenotyping of CT scans to be able to capture hepatic fat. And he was able to create a pipeline that was able to ingest these CT scans and very quickly come up with a metric for the extent of hepatic fat. What was really interesting in this paper that just got published about a few months ago was in looking at COVID-19 patients, we actually found that the extent of the liver to spleen ratio in particular, there was significant association between the liver spleen ratio versus the severity of COVID-19 infections. And in fact, Gaurav did a very, very substantive study using data from multiple different sites across China, Europe, as well as in the US, and showed that there were consistent trends using machine learning to estimate these parameters and looking at the association with severity of COVID-19. In work that we hope to submit soon, Gaurav has also shown that the fat quantification, the liver fat quantification, correlates very nicely with more complex technologies like MR spectroscopy. So in other words, looking just at a CT scan, we've been able to estimate liver fat in a way that agrees extremely well with the assessment that you would get using MR spectroscopy. Now, MR spectroscopy is a challenging technique. It's difficult to do. There's a lot of variability with this approach. But this data, which we have not yet published, shows that from a CT scan alone, we're able to come up with a very, very good assessment of the extent of liver fat, and that agrees very nicely with the spectroscopic imaging-based methods. In work that we've been pursuing with the Cleveland Clinic, Gaurav and Rohan, who's a grad student in our group, have together showed that looking at radiomics, looking at features of coronary artery, actually allows us to predict downstream major adverse events. And we've shown now in a cohort of almost 1,000 patients that looking at features relating to the lumen, looking at the PVAC immediately outside the coronary artery, by extracting a series of different quantitative measurements reflecting the entropy as well as the shape of the coronary artery and the associated habitat, that we could predict the risk of a downstream MACE event. And so this has been really exciting. What about ultrasound? Ultrasound tends to be an imaging modality that's fairly ubiquitous. It's one that one can deploy in places where you don't have access to very sophisticated imaging infrastructure. And so Rohan, again, in the back of the room, has been working with ultrasound images in the context of CKD patients, so patients with chronic kidney disease, and shown that we can start to capture features relating to the ventricular shape, and specifically look at the distension of the ventricular shape longitudinally and find that features relating to the change in the ventricle is strongly associated with downstream MACE events. And so this is work, in fact, I think that the results were just generated in the last week or so. So this is really, really late-breaking data here. A few more examples as start to wind down. I talked about atlases. I talked about creating atlases of the heart. Well, one of the things that a lot of folks in the AI space have been working on over the last 3 years is COVID. And so obviously we got a lot of scans, specifically CT scans corresponding to COVID-19 patients. And the question we asked is what happens to the lung? So if you looked at patients who were normal, patients with severe COVID, patients with mild COVID, what's happening to the lung? And so this was where the atlas-based approach became very useful, and we used it. This was work done by Amog Hiramat, a former grad student in the group. And Amog was able to create atlases for mild COVID, severe COVID, as well as patients with no COVID. And what we were able to discern were that there were significant differences in the shape and the architecture and the morphology of the lung between patients who did not have COVID vis-a-vis those patients who had mild COVID versus patients with severe COVID. You can appreciate here that in patients with severe COVID, there's significant distension, significant changes in the shape of the lung. And we looked at about 4,000 patients here. So the data you're seeing really is aggregate, right? So it's really from a population of patients across multiple different sites. And so the trends that we're seeing are not specific to one particular site or one particular population. It's really across 4,000 or 5,000 patients across the world. Just in the interest of time, I'll sort of keep moving along. Just want to do a shout out to some data generated by Pushkar, another grad student in the group. The point here again that I'm trying to convey is the importance of interpretable features, features that are connected more to the pathobiology of the disease. We've been looking at a number of lung diseases, and we've looked at the lung, we've looked at the shape of the lung. But what about the airway? We know that the airway is going to be compromised for a number of different indications. And what Pushkar has shown very nicely is that we can actually now start to quantify the primary branches of the airway, but also the secondary and the tertiary branches, and create, using his deep learning approach, he's able to tease out a series of quantitative metrics that reflect the architecture and the morphology of the airway. And he's actually shown that there are differences in the morphology of the airway, again, between severe COVID and mild COVID-19 patients. This concept of looking axillary patterns or vessel patterns keeps coming up over and over again. This is an example from work in breast cancer, where we've shown that looking at patients who do respond to chemotherapy versus patients who don't respond to chemotherapy, a lot of it has to do with the twistedness of the vessels associated with the tumor. Specifically, looking at patients who don't respond to breast cancer, what we found is that the vessels tend to be very twisted and very convoluted, very tortuous. In patients who tend to respond to chemotherapy, the vessels, on the other hand, tend to be much smoother, less tortuous, less convoluted. Just in the interest of time, I'm going to keep moving along. One example here in the context of EKG data, as I've been talking about the plurality of data, we perhaps have not taken sufficient advantage of EKG data, though there's been a lot more work over the last 5 years in the context of ECG. But I would still argue that we still have not really utilized the potential of EKG data with AI to really look at predicting treatment response. Yes, there's a lot on, you've got your smart watches to predict risk of AFib. But what about looking at really invasive procedures like CRT? CRT, or cardiac resynchronization therapy, is a very invasive procedure, an extremely expensive procedure. And we have about 5 million people in the United States who are annually going to be diagnosed with heart failure. And a number of them might be candidates for CRT, which is an invasive procedure to try to improve cardiovascular outcomes. But 20 to 50% of patients will not improve with the therapy. And so improved patient selection is something that is really critical. A few years ago, a grad student in the group, Albert Feeney, along with our collaborators in the Cleveland Clinic, got hold of a bunch of data in patients who had undergone cardiac resynchronization therapy. And we were able to train a machine learning algorithm using PCA based off 12-lead ECG data. And actually just using the 12-lead ECG data, we were able to show a very nice clustering of patients who had favorable outcome with CRT versus patients who did not. And you can see here with the Kaplan-Meier curves, just a simple PCA assessment of the 12-lead EKG data allowed us to really discriminate between patients with favorable versus unfavorable outcomes. EKGs continues to be an area that our group continues to work on. This is work that was published in Frontiers in Cardiovascular Medicine just a couple of months ago, where we used machine learning with 12-lead ECG data in conjunction with coronary artery calcium scoring to better predict cardiovascular risk assessment. We actually shown in over 4,000 patients that we could combine calcium scores with EKG to be able to better prognosticate downstream MACE events in this population. And then finally, I just want to end with equitable AI. So I talked about this, the importance of using these approaches in a way that benefits all populations. Unfortunately, a lot of risk calculators, a lot of algorithms that currently exist, a lot of tests that exist out there simply don't work across multiple different populations. I talked about breast cancer briefly. It's an area that our group has been actively working on for the last dozen years or so. Now, there are molecular tests out there to help identify which breast cancer patients are going to benefit from chemotherapy or not. One of the most famous tests, the most commonly used test, is the test called OncoTAR-DX. It's a $4,000 multi-gene assay to identify which women with breast cancer will benefit from chemotherapy versus women who will not. Unfortunately, this data that came out in JAMA Oncology a couple of years ago actually showed it doesn't work in Black women. So we have a lot of tests out there, risk calculators out there, that work in only one population, but don't really translate to other populations. And I think that has to be remedied, and we have to be very intentional in the way that we develop these algorithms. And that's exactly what our group has focused on. This is work we published a few years ago looking at prostate cancer in Black versus white men. While I'll be the first to admit that race is only a socio-political legal construct, it is useful in defining populations. And so while we did use race here to define populations, we were able to identify that there were differences, morphologic differences between Black men and white men of their surgical specimens. And that in turn allowed us to create population-tailored risk prediction models. In other words, we were able to create a population-based model specifically focused on Black men vis-a-vis white men, and actually showed that the population-tailored model for Black men turned out to be way more prognostic of recurrence of prostate cancer compared to a population-agnostic model. All right, so with that, I just want to conclude. So hopefully what I've conveyed is that computational analytics with routine imaging can help address questions in precision medicine, specifically prognosis and predicting response to therapy. I want to sort of reiterate the low-cost aspect of these tools. We're working with routinely acquired data, and that's going to have significant global impact, especially for low and middle-income countries. But I really want to end with the importance of the intuitive basis of these approaches. As we talk about AI, and particularly as we think about AI for clinical adoption, it becomes really important to understand associations across multiple different scales, and really establishing morphologic or molecular interpretable basis to these features or the AI algorithms is, in my humble opinion, going to be critical to really drive clinical adoption. And so that, I just want to do a quick shout out to the amazing students, postdocs, trainees, faculty that I have the pleasure and honor of working with. A number of them are actually in the room here. And of course, you always have to thank the funding agencies who put food on the table. Thank you very much.